Hello friends, myself Dr. Ayush Jain, consultant laparoscopic and general surgeon. Today I am presenting another case in front of you. Though this case is more of a medical side, so surgeon may have a less interest in this case, but still, as this case happened with my own patient, so I am discussing this case in front of you. In this case, we will see that how a simple case takes a turn and become a complex case where the 8 different doctors of multiple specialties and 2 tertiary care hospitals are involved, and all are working towards the same ultimate goal of patient well-being. So let's enjoy this medical movie. It was a normal day for me.
Retrospectively,
I got call from one of my friend.
We say the fancy name, you see.
It was simple, straightforward.
So I was called after OT got completed.
because we do this every day.
And it's chances of this thing occurring any of patient is less than 1%.
But this thing was very learning point for me.
I was right, but in another way. It was a normal day for me. I had a patient, 50-year-old male patient, with symptoms of dyspepsia and was diagnosed as a 4 centimeter elongated single stone in a gallbladder. So I planned the laparoscopic cholecystectomy. The preoperative chest X-ray, ECG and all blood reports were normal. Though patient was a chronic smoker, but the chest X-ray was pretty normal. I mean, there was no any signs of emphysematous changes in chest X-ray. So everything was normal. Preoperative physician fitness was also done. I already assumed that it must be a difficult gallbladder because it was a male patient, and usually the male patient has a very high threshold for the pain, as we see in a case of female which has a low threshold for the pain. So female usually presents early, and that's why the female gallbladders are relatively easier as compared to the male. So I thought it would be a difficult case. I was right, but in another way.
So this was a normal case, normal as in ASA grade 1 patient.
So I did the standard 4 ports laparoscopic cholecystectomy. Ports were placed. There were mild flimsy adhesions. They were removed. Callots was little bit difficult, but not that much difficult, which I assumed.
The surgery went smoothly. During intraoperative period also, there was not much changes in vitals. So it was going smoothly, and the surgery was surgery was about to get completed, surgeon informed us. So we decided to give last dose of Etra before the surgeon takes out the trocar. So,
And whole of the surgery was completely uneventful. Patient was completely stable, and it was less than 1 hour timing starting from the placement of port to the closure of the port. So considering the my thoughts, it was it finished very early. I showed the specimen to the relatives, and then I get descrubbed and starting to write the post-operative orders.
after 15 to 20 minutes, surgery was completed with suturing of skin. So we started to awake the patient. We started lowering all the inhalation agents and everything. And as induction was very smooth and surgery went completely uneventful, we were thinking that extubation must be smooth.
Anesthetists were giving some reversal drugs and were planning for extubation, as they do in all cases. I thought that patient will be extubated in within 10 minutes, so patient could be shifted and I could go along with the patient in the post-operative ward and could explain the relatives about the head-up posture and everything which we usually explain to the relatives after the procedure. But my assumed time of 10 minutes increased more than 20 hours. So let's see the event in that timeline, analyze the case step by step with each consultant's perspective.
So one day I just finished my rounds And after finishing my ICU rounds, I got call from one of my friend. He told me that one of his relative is very serious. Post-operatively, cholecystectomy was done and he was not doing well. So I just called Dr. Ayush that what happened, what is the overall clinical situation as of now. So Dr. Ayush told me that it was simple, straightforward cholecystectomy, no surgically difficulty any he found during the surgery, and he did it very precisely, very nicely. And
First of all, thank you, Dr. Akash, for praising me for my surgery. I called Dr. Akash because patient was referred by Dr. Akash to me for the laparoscopic cholecystectomy. And I called to Dr. Akash that patient is not coming out from anesthesia because Dr. Hardik was there, Dr. Hiral was there, and both were trying to do give reversal drug, because as a surgeon I don't know much what actually they are giving. So I found difficulty in words to explaining to the intensivist Dr. Akash, but I could simply convey him that something is not going straight. So that was the case. When somebody refers to us their own patient, it unconsciously becomes more responsibility on our shoulders. Though each and every patient is important to us, but it is a human nature. When somebody refers to us and we have something concern about anything, then it becomes special to us. So I asked just Dr. Hardik that what has been happened, means why you are not shifting the patient, because usually you always shift the patient. We usually see in the monitor, and where you can say the pulse rate is there and everything is there, saturation is also there. So Dr. Hardik told me that, sir, patient is not following the verbal command, that's why we are not shifting. So I thought, okay, within 2 to 3 minutes it could have been done and shifted.
So we decided after waiting for 10 minutes, we as the flickers appeared in bag for respiratory breathing. So we decided to give reversal. So we started reversal. In reversal, we gave 2.5 milligram neostigmine and 0.5 milligram glycopyrrolate, which comes together as a myopyrrolate. So we waited for 10-15 minutes after giving of reversal, and the movement was there, but it was not satisfactory. The tone and power was not satisfactory. So we thought that it might be because of incomplete reversal. So we decided to give more of neostigmine. So we gave 1 milligram more neostigmine, and then after that we waited for 10 to 15 minutes again to wait for complete reversal. But again the tone was there, but power was not satisfactory, and patient was still not following verbal command, and the breathing was shallow still, and it was labored. As we have given 3 milligram neostigmine, so we were thinking it should be calm, patient should breathe smoothly, but he was not. So we thought that it might be because of CO2 retention, because patient was COPD, patient was a heavy smoker. So we thought it might be because of CO2 retention that patient is not coming out nicely, because he was not following verbal command and the breathing was not as satisfactory as it should be. So we decided to wash out that CO2. So we decided that with patient's breathing, we give more breathing. So we ventilated patient. We supported patient's ventilation with his own ventilation. But even after doing that for 5 to 10 minutes, patient was not following verbal command, and the breathing still was not satisfactory. So we thought it might be because of acidosis, the collection because of respiratory acidosis, because of raise in PCO2. So we decided to go for soda bicarb. So we gave soda bicarb, and we also gave calcium gluconate. We give calcium gluconate to facilitate the reversal action of neostigmine. Tone was there, but power was not satisfactory. Patient was still not following verbal command. Till now, patient saturation was maintained. Is patient on smooth, on his spontaneous breathing also, patient's saturation was maintained till now. But suddenly it started to drop. So patients from 100 to it went to 80% saturation. So then
When the saturation started to go down, initially it was up to 95 to 100, 95 to 100, but when the saturation starting to go down, then it actually realized me that now the something is going wrong, because until that, as a surgeon, we were not involved in the reversal procedure, so we could not see actually the outcome. I was just thinking that patient will come out, but when the saturation gone down, I thought this is not a routine thing, and it will be difficult now the case.
And post operatively it was difficult extubation, so just I rushed there, and there are so many thought process was going on in my mind that what must have happened. I had mainly 3 to 4 differentials. One of the differential was some pneumothorax or tension pneumothorax, because post operatively it is possible that any injury to diaphragm or pleura must have happened and it has caused the pneumothorax. Already they must have created pneumoperitoneum during surgery, and which has exaggerated the response of pneumothorax. That was my first thought process. Second thought process was air embolism or pulmonary embolism, something like that. Third thought process was some cardiac event, like any myocardial infarction or any right heart failure or left ventricular failure. What was the cause? I don't know, but that might be one of the possibility. So any kind of cardiac event that might be caused by either myocardial infarction or any event that has caused cardiomyopathy, stress cardiomyopathy. That was my thought process. The ejection fraction must have gone down, and it might have called pulmonary edema, and this situation must have happened. So I just need to see patient clinically to confirm my differentials.
so at that time, and it's a rule for anesthetists that if we encounter some things like this, we ask for help. So as a rule, I asked for help, and I called my colleague Dr. Vishwal Patel.
So I was called in the operation theatre during the extubation period. When I reached to the operation theatre, the patient saturation or SpO2 was fluctuating between 80 to 90%. So I thought it might be either of these two things. First is pulmonary air embolism, because it was a laparoscopic surgery. This might be a cause, though highly unlikely. Then the second cause, it might be negative pressure pulmonary edema, because there was a delay during the extubation time. So because of the laryngospasm, this might have occurred, as we were getting frothy secretions from the ET tube. So there was definitely a pulmonary edema in the patient's lungs. So after then we did two things. First, arterial blood gas analysis, and second is chest X-ray. So in ABG we got pH to the acidic side and lesser PO2 on PO2 on the lower side, then PCO2 on the higher side, and SpO2 was also on the lower side. So it was classical respiratory acidosis.
So Dr. Hiral called Dr. Vishwal. Dr. Vishwal came there. So Dr. Hardik was there, Dr. Hiral, Dr. Vishwal, three capable anesthetists, as well as Dr. Akash, intensivist, and Dr. Chintan. They too were there, and so there are 5 doctors, and also Dr. Lalit was on the way. So all 6 doctors were there standing in the operation theatre and were thinking what to do and what to take the further step, and thinking that what has happened to this patient. And I was sitting in the corner, because what could I have done? Means I don't know what was happening. And then I thought that if this coli was little bit difficult, I could have explained to the relative that it's a difficult coli, so the procedure was long and the anesthesia was long, so some problem could have arisen. But how could I explain to the patient when I showed the specimen to the relatives within less than 1 hour after the induction? And there was complete fitness, there was medical fitness, anesthetist fitness was there. So what to explain to the patient, that was going in back of my mind.
So I was called after OT got completed, as patient was not getting extubated because he was having continuous hypoxia requiring ventilatory support and not conscious enough to extubate the patient.
So Lalit bhai came and we did the standard 12 lead ECG, and we also called the portable chest X-ray machine, and we went for the standard chest X-ray. And the chest X-ray was another bigger shock for me, because I had seen the pre-operative chest X-ray, and now I was the same person was seeing the another chest X-ray. It looks like me that this X-ray is from another person, because it cannot change in less than 24 hours.
The ECG is just showing sinus tachycardia, and X-ray showing bilateral perihilar opacity, which generally indicate left-sided heart failure, and we call it as a bat wing edema.
And the chest X-ray showed typical bat wing appearance. So the two things which I was thinking, they were ruled out because of this chest X-ray result.
So it was purely a case of left-sided heart failure in a patient having no pre-existing cardiac disease.
So basically in pulmonary embolism, there is a wedge shape opacity which starts from the periphery and then it goes in the center, while here it was opposite. So that's why we could tell that it is a pulmonary edema and not the it is primarily a pulmonary edema and not the pulmonary embolism case. Though this knowledge has been shared by Lalit bhai, but the audio was not clear, so I had to remove that particular video portion of Lalit bhai, and that's why I am replacing this.
We called intensivist Dr. Akash.
So I just went there. When I went, patient was tachypneic and he was very restless. He had heart rate of 160, blood pressure was around 100/70, and oxygen saturation was 90% with 100% FiO2. They were giving with Bain circuit. First we have taken the ECG, and ECG was showing tachycardia. We could not see P wave. The tachycardia was so severe that we could not appreciate P wave. So first of all, we had sedated him properly to look what is actual situation, and we appreciated P wave after sedating him well. Then second thing, we I auscultated simultaneously, and there was crepitations in all four zones of the lungs. There was pink through the sputum coming from the ET tube. So the diagnosis of pulmonary edema was very, very likely. What has caused pulmonary edema, still we didn't know. I looked at the chest X-ray, and chest X-ray was bilateral fluffy shadows, bat wing sign, whatever we call that, and it was showing pulmonary edema only. Then after stabilizing the patient, we had given initially diuretics so that the pulmonary edema component should come down. After giving diuretics, we had asked for the echo machine, and we did 2D echo of that patient on the table, and 2D echo was showing very poor LV function. So LV ejection fraction was just 15 to 20% only. There was anteroseptal hypokinesia with ballooned out LV. That has confirmed my diagnosis that this is the pulmonary edema due to any cardiac event.
So basically we have to give the diuretic to decrease the waterlogged lungs which are there into the pulmonary edema. When we give the diuretic, it moves out the fluids from the lungs, and that's how it gets treated. And 2D echo confirmed our diagnosis. Dr. Akash diagnosis.
Retrospectively, I came to know as I was following this patient. I was there with Vishal Patel since we manage this case together with intensivist Dr. Akash and all the echo, and I was there.
Cardiac event can be this myocardial infarction also, and cardiac event can be stress cardiomyopathy also. What is stress cardiomyopathy? Stress cardiomyopathy is any kind of surgical stress or any kind of stress, septic stress to the body, and which causes the dysfunction of the left ventricle, and it causes ballooned out LV.
So basically whenever there is a problem that left ventricle cannot contract, so what happen, there is a back pressure changes. So left ventricle back pressure goes into the left atrium, and as the left atrium receives the blood by the four pulmonary veins, so the back pressure changes goes into the pulmonary vein, and that lung particularly get edema due to the back pressure changes.
I was pretty confident now that this is the cardiac event. This is flash pulmonary edema, and this flash pulmonary edema should be. There is only two to three things we need to do in this kind of situation. First, we have to give diuretic. Second thing, we have to give nitrates, nitroglycerin. Why? To reduce the preload. So, and third thing, we need to reduce afterload. But right now, it was not the condition that we were able to give any medicines to reduce afterload.
So basically we have to give the diuretic to wash out the fluid, and we have to give the nitrate which causes the vasodilatation. So there will be little bit peripheral pulling of the blood. So blood will stay more in the peripheral circulation because the diameter of the blood vessel has become more dilated, and so the blood will remain into the peripheral system. It will less go into the heart, and that's how the workload on the heart can be decreased. That is basically the concept. Basically I am explaining all this thing because Dr. Akash is intensivist, and I think sometimes the Dr. Akash whatever they speaks is difficult to understand for me also sometimes. That's why I am explaining in a simpler term, because the audience may be the wide.
After stabilizing the patient, we have started nitrates and NTG. We have started NTG infusion. We have given diuretics. We have given already diuretic, and we have given some top of diuretic. Patient was reasonably doing well but still oxygenation was very poor. The persistent pink secretions, prodisputum was coming from the ET, and we decided to take the patient to multidisciplinary unit where to manage this such kind of patient, and so we had taken him to a multi-speciality unit. During transport, it was very difficult transport because patient was constantly desaturating. We had sedated and paralyzed the patient, and patient was desaturating with 100% FiO2 also, and with hyperventilation also. Patient saturation was remaining around 85 to 90% only, and successfully we managed to transport patient to the multidisciplinary unit.
Yeah, shifting was a difficult task, but I was pretty sure that Dr. Akash and Dr. Chintan are there, so I need not to go.
So we shifted the patient to ICU. Patient was sedated. Hemodynamically, there was component of tachycardia. Patient was on NTG infusion, but BP was remaining borderline. It was around 100/70. Patient had cold kami peripheries. There was definitely component of tachypnea. There was desaturation. Saturation was remaining around 85 to 90% with 100% FiO2 on ventilator. So we as usual protocol, we increase the PEEP level to 8, and we have given 100% FiO2. We repeated 2D echo in the ICU also, and it was just 15 to 20% ejection fraction. We had done all the blood workup there. Blood workup was showing troponin, high sensitivity troponin I we have done, and it was around 10,000, so it is sky high. We had done NT-proBNP. NT-proBNP is the marker of heart failure, and it was around 7,800 or something like that. There was component of mild AKI. The creatinine was around 1.3. So our initial aim was to stabilize the patient. So to stabilize the patient, we had given continuous sedation paralytic infusion just to calm him down. We had and we have just given just supportive medication, evaporating to reduce the heart rate, and we had continued NTG infusion. But with NTG infusion, there was component of hypotension and urine output was dropping. So our target was to increase renal perfusion. So we had started noradrenaline infusion just to maintain mean arterial pressure above 65 to 70.
When I went to the ICU, I saw the intubated patient with urine bag, with drain, which I have put after the laparoscopic cholecystectomy, and the 4 different types of infusion pump, and the fentanyl and cortisone. I don't know, the so many things were going on. And by looking at that patient's face and this multiple infusion pump, I realized that what I have done means is this a Whipple operation which I have done? No, it was a simple case of laparoscopic cholecystectomy. Is it the same patient who came to me in my OPD? That sir, I want to go for a gallstone removal, and I assured him that you will be walking and you will able to do all your work starting from the post-op day 1. So that thought first, for a fraction of time that thought comes, and it happens. I think the same experience may be of different surgeon also, but everybody is not sharing the case and I am sharing the case. That's only the difference.
After stabilization of the patient, we involved the cardiologist, and cardiologist was in the opinion that need to do coronary angiography to rule out the acute coronary event, but the patient was not in condition to get coronary angiography done because there was component of AKI. Patient was having some form of lingering sepsis because his white cell count was remaining little bit higher side due to LVF and back pressure changes. He had some congestive hepatitis, and SGOT SGPT was remaining on little bit on higher side, around 200 to 250. So we need to get him settled down for some time. In next 24 hours, gradually the tachycardia was settling, and the patient was maintaining good urine output, and the pulmonary was component was settling gradually. The oxygen requirement and PEEP requirement was being gradually being down, and patient was doing overall well. So what we had given just low dose ecosprin to this patient and just waited for next 24 hours, just stabilized him. We had given just supportive medications. After next 24 hours, patient had good urine output, but creatine was rising. Creatine has gone up to 2.5. Urea had also increased, and but clinically patient was doing well. FiO2 and PEEP requirement significantly was down in next total 48 hours. There was the tachycardia has reduced, blood pressure was stabilized, small dose of noradrenaline requirement was there, but with that he was maintaining good MAP, and there was good amount of urine continuously. He was pouring good amount of urine. No any fever spike or no signs of any lingering sepsis, and patient was doing quite well. The crepitations were reduced, X-ray was clearing, so the pulmonary edema was also component was also reducing. We had repeated 2D echo, and it was the ejection fraction was around 25-30% around that, but still it was severe reduced LV function, and ballooned out LV was there. No major valvular insufficiency during that 2D echo. So we decided to discharge the patient with the supportive medicine. In the supportive medicine, we had continued antiplatelet medicine, statins, and other preload reductive medicines and afterload reduction medicines.
So basically this FiO2, PEEP and all these words are difficult to understand. I know that, because intensivity usually commonly use these words because they are in ICU duty and like that, but audience may be the wide. So the moral of the story is that patient was good. Patient was struggling for the extubation, and patient was trying to remove that tube from from his own mouth, and that is the most happy moment for me as a surgeon. And in all of these the things were going on, to see the abdomen, everything was completely sidetracked. Okay, and I was the only one who is concerned how is the abdomen, because nobody was concerned about the abdomen at that time. But luckily when I see the abdomen on post-op day 2, it was fine. There was no any distension and nothing like that, and we started the RT feed, and when the patient get complete consciousness, the RT was removed and liquid diet and followed by soft diet we started. So that was really a good thing for me.
And then diagnosis was made after 2 days that it was made that cardiomyopathy is there. But what is that cardiomyopathy, how it occurred, what was the reason, that we did not know at that time, because patient was ASA grade 1. So we could not think about anything that could cause cardiac failure, that is also left ventricular failure. that soon in this type of patients.
Then patient was doing gradually better. Within next 3 to 4 days, our aim was just to settle down the patient. We had given low molecular heparin after 48 hours. Our goal was to maintain good anticoagulation, single antiplatelet medicine, plus to stabilize him hemodynamically. So overall patient was doing well with antiplatelet, anticoagulation and other supportive medicines. We had to give diuretic round the clock to maintain good amount of urine. Gradually patient was taking orally, he was feeling comfortable. The O2 requirement after extubation we had to give initially for 24 hours we had given non-invasive ventilator, NIV BiPAP support, and then gradually patient was on oxygen supplementation with 2 to 3 liter of oxygen. He was maintaining good saturation and there was no major tachypnea during this period. Gradually patient was doing better and we decided that now we can shift him to the ward because patient was stable enough to get shifted in the ward. In the ward there was just 1 liter of oxygen. He was maintaining good saturation. We removed the Foley's catheter and he was maintaining good amount of urine. Gradually the AKI component was also reducing from 2.5 of creatine. It has come down gradually to 1.5, but it was remaining 1.5 next 3-4 days also. So overall patient was better. In terms of inotrope requirement, it has come down and it has been we were able to successfully wean off the inotropes. Patient, there was no component of tachycardia. Patient was pouring good amount of urine. Patient was conscious, alert. There was no component of tachypnea, no obvious pulmonary edema component. X-ray was clear and everything was looking absolutely okay. So our next target was to know whether it is acute coronary syndrome or whether it is the stress cardiomyopathy or Takotsubo cardiomyopathy. One of the differential can be neostigmine induced cardiomyopathy also. It is also very known factor that during the reversal anesthetist has to give neostigmine and that neostigmine also causes such kind of cardiomyopathy. What was that? We don't know. But the great factor was after 6 days the EF has become normal. There was gradual drastic improvement in the left ventricular function. So our differentials got narrowed down, and we were very confident that this is the stress cardiomyopathy or Takotsubo cardiomyopathy, because even if it is ACS, there is within 5 to 6 days the EF cannot be normal. So due to the surgical stress, we discussed with the surgeon, with the other our colleagues, ICU colleagues, and our seniors also, and everyone's opinion was the same, that either it is neostigmine induced cardiomyopathy or stress cardiomyopathy, so called Takotsubo cardiomyopathy.
So it was very unusual to know that the patient was gone into stress cardiomyopathy. So, this Takotsubo cardiomyopathy was very unusual to us. Usually we do not encounter this type of case in ASA grade 1 patient, that is also. It was very far from our diagnosis, so, and it's a rare thing. It's obviously a rare thing, but it was there. So there might be the thing that patient has had surgical stress plus emotional stress during extubation, because extubation does cause stress, both emotional and physical. We know that it, but the thing is the cardiomyopathy does not occur this early in those cases, because we do this every day. We extubate patient every day. But this thing was very learning point for me, that in 5 to 10 minutes also this could occur.
The coronary angiography done. The cardiologist had done the coronary angiography, and coronary angiography was suggestive of triple vessel disease, but the disease was in mild form. There was 40 to 50% occlusion of all the vessels, LAD, LCX and RCA, all vessels were occluded 40 to 50%. And it was mild disease. So we concluded that this can be the baseline status of his coronaries. Because due to smoking, there is it is high likely that patient has this kind of atherosclerotic coronary disease, and it is very acceptable to us. So our final diagnosis was it is the Takotsubo cardiomyopathy with some underlying coronary artery disease, but which need not be treated with the stent placement or percutaneous angiography. We need to just give antiplatelet statins and supportive medicines for that. What is Takotsubo cardiomyopathy? Takotsubo cardiomyopathy is the ballooned out left ventricular function and reduced left ventricular function due to any kind of stress. Takotsubo is Japanese word. It means that they use something, the instrument like a pot to catch the octopus. The head of the octopus get caught in that pot, and so during this episode, the heart becomes the ballooned out LV looks like a pot, like a Takotsubo, which is called in Japanese. So
this was typically a Takotsubo cardiomyopathy, which we say the fancy name. You see, it is because of the surgical or perioperative stress, and it's chances of this thing occurring any of patient is less than 1%, and we actually encountered this complication first time in my this whole practice.
So it is not very uncommon thing, but it was very interesting case for us, that a straightforward case which has got complete, and the straightforward surgeries even after undergoing surgery very nicely, there was a new thing which has happened and which has caused all these things, and ultimately the outcome was very good. Patient was very happy, all the doctors were very happy and satisfied, but it was very good learning experience for every one of us, and everyone was happy with the overall outcome. Thank you.
So I hope that you liked this case discussion and my effort to doing all of these things. And if you do like that, please like, share and subscribe. Timeline as well as the different thoughts of all consultant, and by time how the thoughts were changing and how each of consultant we have learned from this event. And I know that these types of cases must be happening with each of us, but everybody does not record it, and I have interest in it, so I does it. And by the way, if you are wondering what is in this cup, it is plain simple water and not the coffee. Thank you.